As you heard, we're going to be talking about the rational use of pharmacotherapy. And just very briefly, I have no particular conflicts of interest or financial disclosure with respect to the ECHO series. So what we're going to do this evening is have a look at how we might identify the most appropriate second and third line glycemic medications and obviously tailor that to the particular patient sitting in front of you. And thankfully, the new changes actually make life simpler than they were before. So as the complexity of medicine increases, we tend to find that so do the treatment algorithms, but I'm hoping to convince you that actually life has gotten considerably simpler. And that is going to be about understanding the rationale for commencing either GLP-1s or SGLT2 inhibitors or both in primary care. And we'll also talk briefly about some of the tools that you could use to help guide you in terms of that intensification. So I want to take you back in time a little bit to where this all began. So back in 2007, which was notable for lots of things, but two in particular. One is it was the year that the first iPhone came out. Can we imagine living without our smart devices? But in the medical world, something that was as impactful was this meta-analysis by Steve Nissen, a cardiologist, and Kathy Wolski, a biostatistician, who published a meta-analysis on rosiglitazone that at the time was really flying high as an agent of high efficacy and the additional benefit of having low propensity for hypoglycemia. But what they found was that there was, despite it being very good at lowering blood glucose and sensitizing the body to insulin, it actually was associated with a significant increase in myocardial infarction, about a 43% increase in myocardial infarction. And this was statistically significant. And there was a 64% relative increase in cardiovascular mortality. And whilst that just missed out on statistical significance, 64% certainly does have you thinking fairly deeply about whether you want to use this agent. And as I say, this had wide-ranging ramifications in the diabetes world. And among the many things that happened was that the FDA mandated that as of that time, any new medications that were to be listed as glucose lowering needed not only to be shown to be efficacious, but also to be safe. So this launched a whole new era. Now with rosiglitazone, some countries banned it, some countries put a black label on it. Another discussion for another night, much of that data was actually overturned and shown to be incorrect. But when that all came out, the die had been cast and we entered the cardiovascular outcome safety era. So there were studies, over 20 high quality randomized controlled trials with over 200,000 study participants. So all new agents that were to be listed underwent this rigorous, not only efficacy study, but safety study. And they looked predominantly at cardiovascular disease, but also other areas of interest such as cancer and renal outcomes. So where did this bring us? It brought us to our current algorithms, and this is a copy of probably the most widely utilized glycemic management algorithm in type 2 diabetes. This is the American Diabetes Association and European Association for the Study of Diabetes consensus statement. And what changed, what was a fundamental tectonic shift in the way we managed glycemia, was that we were no longer just looking at how high the glucose was and how much we had to bring it down. What we were looking at is the presence or absence of comorbidities. And it'll be clear why in a moment this is the case. So the question is, after metformin and lifestyle modification, which is the mainstay of diabetes therapy, has remained the case since the 80s possibly even 70s, metformin first, scaffolded on a healthy lifestyle. But if you're looking at second-line agents, now you ask the question, does this individual have established atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, or are they at high risk? So if you have a look under metformin and lifestyle, the bubble on the right, if the answer is in the affirmative, you can see the next bubble down is consider independently of baseline HbA1c or individualized HbA1c target. So we're not ignoring the glucose, but you would choose these agents because these particular agents that I'll talk about in a moment are our first disease-modifying agents for diabetes. So if atherosclerotic cardiovascular disease predominates, you will choose a GLP-1 with proven cardiovascular disease benefit, or an SGLT2 with proven cardiovascular benefit. Or in fact, you could do both. If heart failure or chronic kidney predominates, your choice is going to be an SGLT2 or a GLP-1 or both. What if the person is not at high risk or does not have these established comorbidities? Let's look over to the left. If A1C is above individualized target, proceed as below. If there's a compelling need to minimize hypoglycemia, you will choose among the options, GLP-1, DPP-4, SGLT2, and probably not going to use a lot of TZDs. So it's going to be GLP-1, SGLT2 again, and possibly you could add a DPP-4. What about if there's compelling need to minimize weight or promote weight loss? Again, GLP-1, SGLT2 appear. So it doesn't really matter whether it's minimizing hypoglycemia, minimizing weight, protection of atherosclerotic cardiovascular disease, or renal disease or heart failure, you're going to have a GLP-1 or SGLT2 in the mix. What about our local guidelines? Not that different, perhaps a little more subtle, a little less obviously stated, but metformin first. You can have sulfonylurea, insulin as first line, but those in dark blue are the preferred agents. Second line, SGLT2, DPP-4, or GLP-1. And then third line, you have a smorgasbord of options. But the little icons, the heart or the kidney, are indicative of the protection that those agents provide. And so what we want to do, of course, is lower glucose, but what we're more concerned about is protecting our patients' kidneys. Diabetes is the leading cause of end-stage kidney disease. We want to prevent heart failure, 30% prevalence in diabetes, or at least we want to mitigate it if it's present. And we want to stop our patients from dying of cardiovascular disease, an event that around 60 to 70% of our patients will succumb to. So whether it's second line or third line, you're going to be going for these agents. In case I haven't got my message across, commence metformin. If there are these comorbidities, cardiovascular or renal disease, or a high risk of these, you're going to go with an SGLT2 or GLP-1 receptor agonist. If the answer is no, and the HbA1c is to target, then basically you're all good. If it isn't, then intensify treatment. And given the data that I've given you, you would be thinking fairly strongly about introducing a GLP-1 or SGLT2. In fact, I'll turn that around. You'll have to think of good reasons why you wouldn't use these very, very good agents. So what are the tools in our toolbox? In Australia, we have a number of GLP-1s and SGLT2s. So the earlier generation, the exendin-based GLP-1s like exenatide, immediate release, Byetta, exenatide, extended release, Bydureon, are based on the exendin molecule from the Gila monster saliva. You've all seen pictures of those, I'm sure, in the early days. And then the later generations, liraglutide, dulaglutide, and semaglutide, are based on a skeleton of human GLP-1. And for a number of reasons, these are preferred to the older generation. SGLT2s, we have dapagliflozin, so these are the gliflozin family, DAPA, which is Forxiga, EMPA, which is Jardiance, and ER2, which is Steglaro. So very quick Cook's tour of current glycemic management, but hopefully the choices now become easier and more obvious.